Hi and welcome. I am Jerry Williams, the founder and president of Myositis Support and Understanding. As most of you are aware, today is Rare Disease Day, and myositis is a rare disease. As part of Rare Disease Day, we want to showcase our collaboration with Idera Pharmaceuticals in helping to spread awareness about the Phase 2 clinical trial for adults with dermatomyositis they are running and currently recruiting patients for. MSU is a patient-centered nonprofit organization. And part of our goals are education and awareness, and this is why we have collaborated with Idera. As part of Rare Disease Day today, we figured it was a great day to invite Idera to help you understand more about the trial for rare disease dermatomyositis. Therefore, we have invited them to join us today to discuss more about the Pioneer trial. Before we get started, I would just like to make note of some important things that we ask you to do. We ask that you please do not interrupt during the presentation. There will be time for a few questions at the end. Please ensure that your microphone is muted to prevent background noise as an interruption. We may mute your microphone if needed. And as I mentioned, please check your chat section. This is where, towards the end of the presentation, you will type your questions, and then we will ask Dr. Horabin to answer those that may not have been covered during the presentation. So now I would like to turn things over to Dr. Joanna Horabin. She is a physician and the Chief Medical Officer for Idera Pharmaceuticals. We certainly welcome you, Joanna, and we certainly thank you for taking the time out today and joining us and talking about this important clinical trial. Welcome.
Well, thank you very much, Jerry, and thank you very much to the patients that are joining us today. It's wonderful to see some of your faces, although you're very, very small on the screen that I can see. So I know that means I'm also very small to you. It's particularly fitting that we should be doing this today on Rare Disease Day. And we really want to recognize also all of the support that we as the company and you, the patients, are getting from our partners at the Myositis organization, because it's really a team effort to try and bring new drugs to patients like yourselves. So I'm going to move now, and we're going to start sharing the slides, so you won't see me as much, but I'll be here and ready to answer your questions as we move forward. Before I start talking about the study itself, there are a couple of things that I need to note. First of all, Idera Pharmaceuticals is a publicly traded company. We are traded on the NASDAQ stock exchange. And that means that we have to make certain disclosures. And in particular, what it means is that I have to alert you to the fact that there are risks in our business, and those risks are detailed in the public filings we make to the SEC. And we make those on both an annual and a quarterly basis, and people are welcome to take a look at those if they're so interested. The other thing that I'd like to say is that, of course, we're not here today to give you any personal medical guidance. And so if you have questions about your own disease or the treatment that you're receiving, those really should not be addressed to me, but they should be addressed to your own physician or your healthcare provider. So with those caveats behind us, now we can actually move on and talk about the matter in hand. And really what I want to talk to you today about are three things. The first goal is, well, first of all, of course, to thank the Myositis Association and Myositis Support for the wonderful collaboration we have and all of the expert input that you have provided directly and by connecting us with patients and with KOLs. We really appreciate all of that. You are the patients we aim to serve. I also want to briefly introduce the company, Idera Pharm, and then we'll move on and talk a little bit about our drug, IMO 8400, which is an investigational agent that's being tested. And as an investigational agent, that means it's not yet been approved by the FDA or by any other regulatory agency and can only be obtained through clinical trials that we are running. And then thirdly, and I think very importantly, we really want to share with you the detail of the clinical trial that we're doing, and also for those of you that are personally interested or have friends or others that may be interested, to also share information about the study and how you could be a participant in it. So that's really the goals for today's presentation. So first of all, a little bit about Idera. So Idera is a biotech company, and we may be small, and that's essentially all of us in that picture that you can see there, so it's about 70 people. As I said, we may be small, but we have big ideas and we have big goals. And we place patients essentially at the center of everything that we do at Idera. What we want to do is bring new treatments to patients with rare diseases or rare cancers, and that is the only reason that we exist. Our team is based in two places. We have part of our team up in Cambridge in Massachusetts, and that's where our laboratory research is carried out. And then we also have a team down near Philadelphia in Exton, say just outside Philadelphia, which is where I'm talking from today. We actually have a long history of scientific leadership in the space of nucleic acid therapeutics. And the research that the researchers at Idera have done over the years have led to some important and unique insights into the role of what we call toll-like receptors. And I'm going to talk a little bit more about toll-like receptors, or TLRs, as we often refer to them, in a minute. And this particular scientific understanding also helps us understand what the role of TLRs might be in dermatomyositis, and therefore how we might be able to impact dermatomyositis by developing drugs that interact with the toll-like receptors. So that's a little bit about our company and what we've been doing. There's more information about our clinical trials and, in fact, all of our science on our website if you're interested to find out more after you've heard today's presentation. But before I talk about the clinical trial, first of all, I'm going to talk a little bit about some of the background science about toll-like receptors, and I'm going to keep this at a pretty high level. As I said, you can find out a lot more from our website if you're interested in going deeper into the science. So what's a toll-like receptor? Well, as you can see here, we think about toll-like receptors as some sort of policeman, which is, as you'll find out in a minute, a really good analogy, because toll-like receptors are proteins, and they're proteins we all have, and they're an important part of our body's immune defense system. Essentially, they're a part of our natural defense system. TLRs help our body recognize things that are invading our bodies that shouldn't be there. Things like bacteria or viruses or cells that are sort of in the wrong place. And for example, you can think of aberrant cells like early cancer cells as being things that shouldn't really be here. And our toll-like receptor mechanism is in part there to try and help us manage these foreign invaders. So in general, the TLR system is a good thing because it sends warning signals to our immune system that it needs to get ready, it needs to mobilize and attack these invaders, if you like. And the way the TLRs work is by recognizing fragments of DNA or RNA, essentially small bundles of nucleic acid that are produced by these pathogens or by abnormal cells as they divide and multiply. And you can see in the cartoon we've got these things floating around in the milieu inside the body there, Sputnik-looking things and things with long tails. So these are considered to be the pathogens that our toll-like receptor system nature has set up to protect us against. So in that case, that would mean, I think, that toll-like receptors are a good thing, right? And that would be an obvious conclusion that we could draw from this cartoon. But the reality is that toll-like receptors are a good thing most of the time, but not all of the time. So in situations where you've got damaged tissue, the toll-like receptor system can actually become the bad actor in this story. And so when tissues in the body are damaged, for example, as we're showing here, damaged muscle or skin cells, which you may have if you are a patient with dermatomyositis, the nucleic acid fragments from those damaged cells can be recognized by the toll-like receptor system. And then that's when it can become the bad actor. Because just as the toll-like receptor system is turned on to effectively get rid of foreign pathogens when they invade our bodies, the toll-like receptor system can also be turned on by these fragments of your own cells and start to attack those cells and where they came from. So here we're showing you a cartoon of what a toll-like receptor, this bundle of protein, looks like in a muscle cell or a skin cell. And so what happens now is that the toll-like receptor system is turned on, and then cytokines, which are specialized proteins, are released. They stimulate specialized T cells, which are specialized types of white blood cells, to mobilize and go back to the site of the damaged tissue. And essentially, the immune system is now mounting a response against your own tissues. So the very system that nature put in place to help us deal with unwanted foreign invaders, the bacteria and viruses that can invade our bodies at times, is now being turned against our own cells. And when that happens, there's an immune activation, there's an immune response in your damaged muscle and skin cells. And instead of dampening down the inflammation that's causing symptoms of dermatomyositis, it actually upregulates it and makes it worse. So really what we've got here is a vicious cycle which is kept going or perpetuated by the toll-like receptor mechanism. So that's why I say it can be a good actor in normal circumstances, but when it's overactivated, it's essentially a bad actor because it keeps the cycle going. So now let's think about this a little bit more specifically in dermatomyositis. So really there's three things here. So in dermatomyositis, we know now that there are certain of these toll-like receptor proteins that are actually overexpressed in the muscle tissue of patients with dermatomyositis. We can actually find that and show that. What happens because of this expression of those toll-like receptors is that we get these so-called cytokines, these inflammatory proteins, which then arm the immune system. And it's really interesting to see that work done by some of the physician scientists that are actually involved in that clinical trial have been able to correlate the finding of those cytokines in patients with the activity of the disease, either in the muscles or in the skin. And so they've also been able to show that if you can reduce those cytokines, that actually tends to go along with a reduction in the symptoms. And really, that is what has informed the hypothesis behind this study. So if the activation of the toll-like receptor can cause the induction of inflammatory cytokines, which makes the symptoms worse, maybe turning off the toll-like receptor mechanism could actually reduce the cytokine expression, reduce that immune stimulation, and make the symptoms get better. So at its core, that's exactly what we're trying to do with our program. Now let's talk a little bit about our drug. So we call this drug IMO 8400. And I've already mentioned nucleotides and DNA and RNA. IMO 8400 is actually a nucleotide, and that means that we have a short string of nucleic acids. And you'll probably remember from your high school biology, or if you've done science more recently, that nucleic acids are actually part of the building blocks that make up DNA and RNA. And we've already talked about the fact that toll-like receptors get activated when they sense that RNA or DNA or fragments of nucleotides are around in the body. So IMO 8400 is an oligonucleotide, but it's been designed specially so that the TLR system will recognize it. But most importantly, it's been designed not only that the TLR system recognizes 8400 as an oligonucleotide, but that when it recognizes 8400, it turns off the toll-like receptor system. And in particular, it turns off specific proteins within this broad class of proteins that we call the toll-like receptor system. So in other words, when the toll-like receptor system sees 8400, it knows it should be turned off. It's a bit like adjusting a dimmer switch on a light, if you like. So when 8400 is seen by the toll-like receptor system, then the light gets dimmed, the activation gets dimmed. So that's the concept of this drug. It's a drug that we use by giving as an injection, and we use a very small amount of the drug, so we can give a very small injection just under the skin, which is called a subcutaneous injection, and we give it just once a week. And as I mentioned up front, this is an investigational medicine at the moment, so it's not being approved by anybody, and you can only get it if you're part of a clinical trial. The drug has already been tested in about 100 human subjects, Some of those were healthy volunteers. And then we've also treated a number of patients with rare forms of lymphoma and also patients with another disease which affects the skin, which is psoriasis, which is another autoimmune disease. In general, 8400 has not caused a lot of side effects. It's actually been quite well tolerated. Some of the patients in the lymphoma studies have had a couple of more serious adverse effects. In particular, 2 patients had to stop the study because they had a worsening of the joint pain and inflammation they had. And then another patient with a very complicated story had episodes of infection or sepsis, although in fact that patient was able to continue taking the drug. As you might expect in a study with patients with a very advanced form of cancer, we have seen 2 people who died while they were on a clinical trial with 8400, but there's nothing to suggest that the drug itself had anything to do with those deaths. Unfortunately, those patients already had a very advanced form of cancer. And the most common side effects we've seen with 8400 have really been quite mild. We have seen a little bit of local reaction at the site of injection, and so for that reason, in the clinical trials of this drug, we rotate where we inject the drug. So it's injected every week, but it alternates between different sites, so you don't have it injected in the same place every week. And then we've seen some other mild side effects in patients who've been treated with this drug, as listed on the bottom of that slide. But in general, really very well tolerated. So now let me talk a little bit about how we approach the development of 8400 in dermatomyositis. And the first step here was to try and get evidence of what we call proof of concept. So we had a clear hypothesis, which is that if we could turn down the TLR mechanism, we may be able to break the vicious cycle of inflammation and damage that was caused. And so we looked first to another autoimmune skin condition called psoriasis, which is a lot more common than dermatomyositis, and therefore it was easier to do a clinical trial with this in this disease. And there we were looking at a much shorter period of the use of the drug as well. And we were looking at something called PASI, which essentially is a measure that we use to see both how much skin is involved and how severely the skin is involved in psoriasis. And the good news is that in a small study in psoriasis, we were able to show that we did actually have a benefit in some of the patients, which to us seemed like an interesting proof of concept that we could perhaps break this vicious cycle that is manifested by the TLR mechanism. So with that data in hand, we now wanted to move to a rare disease, because as I said, that's really the focus of Idera, and that's when we started to think about dermatomyositis. And so in the study that we're doing with dermatomyositis, again, we're focusing particularly in the skin effects, and we're using a scale which has been developed specifically for testing drugs in dermatomyositis, which is called CDASI, and is also looking at the extent of the damage and the inflammation in the skin. So in some ways, it's a little like the PASI score that we used in psoriasis. And then, of course, the other thing that's important in dermatomyositis is that patients often have involvement of the muscles as well. And so we're using some of the criteria that have been developed to assess the effect of drugs in myositis, or in situations where you've got muscle inflammation. So now let's talk a little bit more about the study itself. And on this slide, you can see an outline of what we call the study design. Now, we want to conduct our studies at Idera in a very rigorous way, because we know that, especially when you're working in rare diseases, every single patient is a really precious resource to the whole of the community. And we want to make sure that we do the very best design studies that we can in the most rigorous way, so that we can use the smallest number of patients to try and get an answer. And so that is why this particular study is being done in what we call a double-blind, placebo-controlled fashion. The double-blind bit means that neither the physicians involved in the study or the company or the patients actually know which particular treatment they're going to get. And in this study, we're looking at 2 active doses of our drug, and we're also looking at something called placebo, which is essentially a dummy injection. So instead of getting an injection of the drug itself, the subjects get an injection of saline. We know that that's not always seen as a very attractive thing to patients, but it is the quickest way that we can get to a really good answer about whether a new drug is actually working, because it allows us to do this in a very rigorous, unbiased fashion. And so in this particular study, twice as many patients get the opportunity to have the active drug as go on to placebo. The study is being done all over the US and also in sites in Europe. And the main goal of the study is really to assess whether or not, when we inject 8400, we can impact this TLR mechanism and stop the vicious cycle that is causing the prolonged inflammation and damage in both the skin and the muscle. But our primary goal is to look at the skin. And as I said before, we're giving the drug once a week in a subcutaneous injection. And in this study, we're actually treating the patients in the study for 6 months, so 24 weeks. Whereas in the psoriasis study, this was a much shorter study because it was the first study we really did in a patient population with an autoimmune disease. So let's talk a little bit now about what are the characteristics of the patients that we're looking for to come into this study. And it's important that when we're doing studies like this, particularly relatively small studies, that as far as possible, the patients are very similar to each other, because that then allows us to compare the effect of the drug in one patient against another patient or group of patients. If the patients were very different, we would need a lot more patients to try and do the experiment. And so this is why the so-called inclusion-exclusion criteria are actually very tightly controlled. So as you can see here, we're looking for adult patients. We're also looking for adult patients who've got a diagnosis of dermatomyositis, and it must have been made while they were adults, not when they were younger than 18. So patients with juvenile dermatomyositis are considered to have a slightly different type of disease, and so we're not including them in this first study. We do recognize that it's hard for patients to give up all of the therapy that they've been on, and so we allow 2 background medications as, if you like, the baseline as patients come into the study. One of those can be corticosteroids, up to a maximum amount of 20 milligrams per day, and then we allow another immunomodulatory medication. And so there are a number of different things that a patient can remain on throughout the course of the study. There are certain things, though, that we think would interfere in our ability to assess the impact of our drug on the disease, and those medications are restricted. And so we have to make sure that if a patient has been on those medications, they've stopped them several months before coming into the study, and that would include rituxan and also the antimalarials like Plaquenil. We also want to make sure that, as I said, that the patients are rather similar to each other. So some of the patients with more advanced disease may have less ability to respond to a new therapy, and so for the purposes of this first study, we're excluding patients that have got severe interstitial lung disease or severe dysphagia. And the other thing that we're excluding also are patients who've got active cancer. So those are the things that we're looking for in terms of the patients that we're bringing into the study. So now in terms of what are we actually studying in the clinical trial, as I mentioned, what we call the primary endpoint, so this is the endpoint that is most important to us and is really going to determine whether the study is a success or a failure, is this endpoint called CDASI, the Cutaneous Dermatomyositis Disease Area and Severity Index. It's a mouthful, that's why we call it CDASI. This essentially has been developed specifically for dermatomyositis, and the physicians who have developed this know that if you see an improvement in this scale, that is also associated with patients reporting that they feel better. So it's not just that the doctor can see a difference, it's also that the patient notices the difference, because ultimately that's what matters, right? It's how the patient feels, not how the doctor feels. It's a relatively simple scale. As you can see, you can do the whole thing on one page, and this is completed by a doctor or one of the healthcare team at the centers that are doing the study, and we do it at the baseline before you start taking the treatment, and then we do it at intervals throughout the study and at the end of the study. And the goal is to take each group of the patients in the study and compare whether the patients who are on treatment did better or worse than the patients who are on no treatment. So this is essentially what we're doing in terms of the primary endpoint. And then, as I mentioned, it's important to look at the other symptoms of dermatomyositis as well. And so we are looking at measures of the symptoms that patients have, particularly in their muscles. And so we're doing a number of different tests, which include things like testing how strong your muscles are in the manual muscle testing, and also looking at whether or not we can improve how far you can walk or run over the course of the study, how long it takes you to get up and go from a chair, climbing a stair, for example. All of these things are ways that we can assess whether the drug may be working. And then importantly, we're doing lab tests, and these are done for a number of different things. One is we want to look at those all-important cytokine proteins that I mentioned earlier on, to see whether we can impact those and get an objective measurement of whether we're really changing the inflammatory process in your body. And then we also ask that patients give us biopsies of the skin. And that's, again, so we can look directly at the cells that we think are impacted by the TLR mechanism, and hopefully show that when we use this drug, the inflammation in those biopsies actually changes. I hope that we'll see that it gets better. And then, as I said, I'm really keen to see that this treatment not only looks better from the point of view of what the physician is measuring, but that it also makes patients feel better. So we use a so-called quality of life assessment as well. So for patients who are interested in the study, I'd like to now tell you a little bit about where the study's going, how you can get involved, and what you would expect if you become a volunteer patient in our study. So for today's purposes, we're just showing you where the study is going on in the US, and if you can see, it's going on in a lot of different centers all over the US, which is wonderful. We hope that most patients are able to get access to one of these centers. And if you are interested to participate, there are a number of ways that you can start that ball rolling. First thing really is to contact either the company directly. You can contact us, or you can contact one of the clinical sites that was on that map a moment ago, or you can talk to your own physician and learn more about the trial. And we certainly would recommend that at some point you do talk to your physician, because they're the doctors that know most about you, and they'll have a sense of whether or not this is an appropriate opportunity for you, knowing your medical history. If the trial does seem to be interesting, then the first thing that would happen is that you would have a conversation with one of the clinical trial team at the site that's closest to you, and over the phone they can ask a number of questions which will give them a very clear sense of whether or not you might be eligible for the protocol. If that is the case, then you'll be asked to share some of your medical records so they can check particularly the important question of what other medications you're taking and what medications you've had in the past. If all that checks out, then you would be invited to go to one of the clinics to have a screening visit. And at that point, you would be seen by the physician that is the investigator for the study. The investigator would then be able to go through the detail of the protocol with you, all the possible risks and benefits, and only after you've had an opportunity to learn more about the study and ask all the questions that you have or that your significant other or friends ask you to ask, only at that point would you be asked to sign an informed consent to join the study. If you go forward with that process, then the site will take some important baseline measurements, both assessing your disease state and also a number of different laboratory tests, so blood tests, that will make sure that you're eligible. And sometimes we need a number of additional tests to be done, and so sometimes that screening period can take a few weeks. and we allow up to a month for all the different tests to be done at the baseline. And then once that has all been conducted satisfactorily, then you'd be invited to come back to the clinic for your baseline visit, and you'd also receive the first dose of the study medication. And then after that, and I'll share the schedule with you, after that there's a whole list of different things that will happen at regular intervals. And as I said, the total course of the study, if you have a month of screening as well, could be just over 6 months, basically. And on the next slide, you can see here's a sort of timetable of what gets done when. So at the top there, you can see the different assessments that we're doing in the skin. So we're looking at the SIDASI measurement, which we've talked about. One of the things that we think is really important to you, the patient, is the itchiness of the skin lesions. And so we're very keen to see whether we can improve that, because we know how irritating that is. It is really important to the research that we have biopsies of your skin before and at the very end of the study. That will be incredibly informative to our research folks and to the investigators as to whether or not the drug, if it does work, is working in the way we think it is. And that will be really helpful as we design additional studies and decide what else to do with this drug. And then the other thing which is very important to us is that we need to make sure that we can look at the SIDASI scores that are done by looking at your skin and marry that up with photographs that are taken at the same time, so that we can assess that the SIDASI score is being assessed in the same way at all of these different sites across the US and in Europe. Now, those photographs, of course, would never be made public in any way. They won't be made known to the company. And if there was ever any thought of using those photographs, you would be asked to give your consent, a separate consent for that. And those photographs, of course, would be used in an anonymous way. And the sort of reason why people might want to use the photographs could be, for example, if the study turns out to be positive and the scientists want to publish their results to share with other scientists and physicians working in the field of dermatomyositis, they may want to take the data to a scientific meeting and share it there. And that could be very useful to show photos. So that would be the type of reason why you could be asked to consent to have those photos shared, but always in an anonymized way. And then the other things that we'd be doing to monthly intervals as well would be just general assessments of your well-being and your health, and also the tests of your muscle ability, and then all of the lab tests. And then as you can see on the bottom, the study drug is going to be given once a week. So some of you might be thinking back to that map we showed a moment ago and thinking, well, that's all fine and good, but I don't live that close to any of those sites. So does that mean I can participate? How would that work if I have to go and get an injection every week? And so we've obviously thought about that, and we have a number of ways of making sure that we can help you, the patient, help us move this field forward. So our goal is to make the study accessible to any patient that's interested and eligible, regardless of where you happen to live, and certainly regardless of whether or not you have the financial ability to get yourself to one of the sites. And so we offer two things here that we hope it will make it a lot easier for patients to get to the investigative sites. The first is that we actually have a travel support program, and that means that both you and any necessary caregivers, because we recognize particularly for patients with muscle involvement, you may need other people to help you get around. So both you and the caregiver are eligible to get reimbursement of any expenses that would be required to get you to and from the sites. And you can see the list there. It's, we're trying to be very generous about how we interpret the approved expenses. And we make it very simple. As you can see, there's that little MasterCard there that you can see that's on the right-hand side. It's as simple as that. It's essentially swiping a MasterCard so that you don't have to pick up the tab in the first place. The second really important thing that we have organized is a home nursing program. So patients do need to go to the sites once a month for the regular checkup, and to have the SIDASI and the muscle scoring assessments done. But for the injections in between those visits, we can arrange for a home nurse to come to you either at home, or it could actually be at your place of work, wherever you will be, and they will come and they will give you the injection. They will do an assessment to make sure that everything's going the way it should, and do a screen for any side effects that we have. So we're trying to make it easy for patients to participate in this study. We really value your participation. So again, we just want to give you some important information about how you can get more information about the study. And so there's a couple of email addresses that are up there. I'll give you time to take a screenshot of this page so that you've got it for future reference. You can email us at patientinfo@iderapharma.com, or you can leave a phone call, you can leave a message there, and that line will be picked up by either myself or one of my team. And then you can also go online to our website, to our dedicated clinical trial website, and that will give you a lot more information about the study too. And when you go to that website, you can download some of that information. You could even print it out, and you could take it with you to your physician to share with them so that they could see more about the study that you're thinking about. So that really is all that I wanted to cover in the actual presentation itself. I think we've probably got about 10 minutes or so left for questions, and I'd be very happy to take questions from anybody who has any questions to offer.
First, Joanna, Dr. Horabin, thank you so much. What a wonderful presentation, and what a wonderful clinical trial. I have never seen such a patient-centered clinical trial in all my years. So thank you and your team for all that you're doing to make it accessible to patients. I'll start with a question. I know that it seems that the focus is more on the skin, and then secondly, the muscles. Is there a chance that this possibly, in your opinion, could work for other forms of myositis, such as polymyositis in the future?
So I think the underlying hypothesis would extend to other forms of myositis. In this first study, we chose to look at the skin form because we felt that was a more sensitive test and would require a smaller number of patients than looking, first of all, at the muscle symptoms. And so our first goal here is to try and do our research with the minimum number of patients we need to get a proof of concept. And then if we see something really interesting, then we could think about expanding it to a broader population of patients.
Great, thank you. And one other question, would patients diagnosed with like amyopathic dermatomyositis, would they qualify?
It really depends on whether they meet the specific eligibility criteria within the protocol. So, and as I said, the most important thing is that patients do need to have quite a lot of skin involvement.
Okay.
So that's the first hurdle. If patients have muscle disease, then that is also really interesting to us, and all patients will be tested for the impact on muscle disease as well.
Great, thank you. Who else has a question? Since we have a small number of participants, just let me raise your hand, or no one has any questions?
I put one in the chat box.
Thank you, Dawn. Okay, skin biopsy question. Are you going to use the one done by the doctor and another done by the study? Will there be muscle biopsy as well?
So we are not requiring muscle biopsy. Although if a patient has had a muscle biopsy, we would definitely want to collect the information because that would probably help us understand the degree of muscle involvement in that patient. The skin biopsy is really what we're trying to do there is to look to see whether that's underlying hypothesis that the inflammation is caused by the activation of the toll-like receptor proteins and cytokines associated with that activation. So we're really looking to see is there evidence of that at baseline, and then does that change at the end of the study? So if you've had a biopsy done previously, it's probably unlikely that it would be a satisfactory biopsy for this purpose, because we need to treat it in a certain way and it needs to be analyzed in a certain way. Does that answer the question?
I believe it does. She has a follow-up question that she also has Hashimoto's. Would that exclude her?
Not as long as it's controlled with her medication, but that would be something for her physician to assess.
Okay. All right.
We understand that patients who have one autoimmune disorder often have other autoimmune disorders as well.
They seem to love company.
They do.
I have another question, and I briefly touched on this prior to our collaboration, and I don't think that now is the time for it. But would this be considered for an orphan drug the orphan drug status that would provide you with benefits in getting this to the market if it is successful?
Yes. So dermatomyositis is clearly a rare disease which satisfies the FDA's requirements for orphan drug.
Great.
Absolutely.
Okay.
And the good news about that, for people who may not be familiar with it, is that because the FDA recognized that it's challenging to do development in orphan diseases, they understand that, and they work with us very carefully to design programs so that we need only a relatively small number of patients. We need the right number of patients, but hopefully a smaller number of patients than if we're testing a drug for hypertension, raised blood pressure or something like that. So it is an important advantage.
Okay, thank you. We have a question from Fiona. Why do you test muscle strength through, I assume that's manual muscle testing, T8, instead of functional index 2, which tests our muscle strength better?
So I think this really comes from the input that we've had from the physician scientists who are working in this field and who've been involved in the development of the suite of tests that we call IMAX. IMAX is being used now as the primary endpoint in another study in dermatomyositis, so that it makes some sense if we use the same endpoints across different studies. It allows us to compare to a certain extent one to the other. And sometimes we use endpoints in clinical trials that are not necessarily the same that we would use treating an individual patient, because again, we're looking at a population of patients rather than an individual patient.
Okay.
Does that answer your question?
I can see you. I hope that answers your question, because I can see you.
Yeah.
Good.
Maurice.
My skin involvement with dermatomyositis is only evident when I'm in a flare-up. How does your study sort of preclude people's skin involvement clearing up on its own or through their own medication rather than the IMO 8400 drug?
Well, that's a very important question. So the first thing is that we try and have patients at baseline who are relatively similar to each other, and that's why we actually require a certain score on the CDASI as a means of entry to the study. And then for the really technically inclined, we even further divide those patients. And so the patients that are have a lower end of that scale, that we have above the cutoff but still at the lower end, are stratified into one group and then randomized into the three. And then the patients that are at the higher end of that cutoff are stratified into another group, and those patients are randomized into the three arms. So that's one way we do it. And then the other thing is by including the placebo, because what that means then is that, sorry, we're about to lose power, but I think we're getting it again. So the other thing is about including the placebo, because that really is the ultimate control to show that there is a group of patients where nothing new is being introduced. And so if the disease sort of got better by itself, we would see it in those patients. And so that's really the way we control for it. But it's a very good question, because in these diseases where there are flares, intermittent flares, and things wax and wane, we do need to control in that way with placebos.
Thank you.
Thank you. Anybody else have a question? Okay. Well, if there's no other questions, I want to sincerely thank Idera for joining us today, and your team is doing an amazing job, and we are so proud to have collaborated with you, and we will continue helping you to recruit patients and to find patients that are suitable. And it's just it's a wonderful trial. I mean, I don't think anybody could disagree on that, and I just applaud you and thank you guys for everything and for really focusing on the patient.
Well, thank you, Jerry. We really appreciate the collaboration, and of course, the patients are not only the people that we hope to benefit, but they're the essential tool that allows us to do our work. And so we really need to thank the patients that are participating in all of our studies, particularly in this one, and there are already a number of patients on this study, and so we hope that others will join soon and we can get the answer, because that's what we're all here to do. So appreciate everybody being on the call. Thank you so much, and I hope everybody has a very good rest of the day and a very good rare disease day.
And you as well. Thank you so much, and keep up the great work.
Thank you, Jerry.
Thank you.
Everybody enjoy your day.
Thank you. Bye.
Bye.
Bye.